Welcome back. We are now going to begin with the nephrotic syndrome. Now, nephrotic syndrome is also a collection of syndromes, and the hallmark feature is the proteinuria, which is greater than 3.5 gram per dl. Now, that's because we have the increased capillary permeability, and that would lead to loss of the plasma proteins. So, proteinuria, which is greater than 3.5 gram per dl. Now, this is in contrast to the proteinuria, which is seen in nephritic syndrome, which is less than 3.5 gram per dl. Now, we also have the hypoalbuminemia, which is because of the loss of albumins, of course, and that would lead to edema. And the edema is particularly the soft and the pitting edema. It's around the eyes, it's the periorbital edema, or it can be generalized, which is anasaka. Now, the globulins are also lost. That would lead to hypogammaglobulinemia, and that would also lead to increased infections. Recall that immunoglobulins are decreasing, so that would lead to infections, particularly the staphylococcus and the pneumococcus in the nephrotic patients. Then the antithrombin 3 is also lost, and that would lead to recall that antithrombin 3 is actually prevents the hypercoagulous state by inactivating the factor 5 and factor 8. So that would lead to hypercoagulous state, and that can cause the renal vein thrombosis in the nephrotic patients. Now, the hyperlipidemia and hypercholesterolemia is also seen, and that's because of the increased production, but the transport is defective. Now, recall that for the transport of lipids, we require the protein component. For example, the ApoB100 is required. So because of that, you can imagine that there is hyperlipidemia. Okay. Now, the first one is the minimal change disease. Is the most common cause of the nephrotic syndrome among the children of age 2 to 6 years. The name minimal change gives us a big hint that the glomeruli actually appear normal in case of the light microscopy, and we don't have any immune complex deposition. However, we have the immunologic basis, and that's high yield, guys, because we have the association with Hodgkin's lymphoma. And now, if you see that immunologic basis is there, it's cytokine mediated. And recall that in Hodgkin's disease, we have T cell mediated dysfunction, and that is causing the its association with the Hodgkin lymphoma patients. Now, in the minimal change disease, we have the normal appearing glomeruli as from the name, but one of the characteristic feature is that we have the lipid depositions, particularly in the proximal tubule. Then we have the negative immunofluorescence patterns, obviously, but one of the feature again is that it has effacement of food processes. Now we will see ahead that effacement of food processes is also a feature of membranous nephropathy or diabetic nephropathy, but the diagnosis of MCD, remember, is dependent on the normal appearing light microscopy, negative immunofluorescence pattern, and its excellent response to steroids. The most common cause of the nephrotic syndrome in children is MCD, and we won't see any hematuria or hypertension. Then proteinuria is selective. Now, this requires explanation. The proteinuria, see, there are two types of proteinuria, selective and non-selective proteinuria. And whenever we have the selective proteinuria, then the low molecular weight plasma proteins are lost, and those are the two proteins, albumin and the second one is transferrin. Okay, so this is the feature of the MCD, but in case of the membranous nephropathy or in case of the FSGS, we would have non-selective proteinuria. We will see that ahead. It has excellent response to steroids, and this may progress to focal segmental glomerulosclerosis. Now, what is focal segmental glomerulosclerosis? It's the most common cause of, again, nephrotic syndrome in adults and Hispanics, African Americans. Now, the cause of the FSGS is usually idiopathic, but it may be associated with HIV, heroin, sickle cell disease, and obesity. It may be secondary to the IG nephropathy. Now, the sometimes whenever we destroy a tissue or there's a loss of tissue, we see a sclerosis and fibrosis over there. So it is an adaptive response to the loss of the renal tissue, say for example in renal ablation. Then the FSGS is of two types actually. It can be steroid resistant, and the other one can have a good response to the steroid. And the mutation of the podosin, alpha actin 4, and TRPC6 is particularly the steroid resistant ones. Now, what are these? Let's see them in the next slide. Now, the nephrin, podosin, and actin all of these three are involved in maintaining the filtration slit pore size. So recall that this over here is actually the podocyte fruit processes, and this is the visceral part of the glomeruli. These are the visceral endothelial cells. Then this over here is the basement membrane, and these are the visceral epithelial cells with the food processes as I marked earlier. So the damage to the nephrin would lead to phenotype of the congenital nephrotic syndrome, and damage to the podocin would lead to the focal FSGS, which is familial again and steroid resistant, and damage to the actin would also lead to familial FSGS, which is again steroid resistant. TRPC6 is actually an anion transporter, and damage to that, sorry, the mutation to that would also lead to steroid resistant FSGS. When we say focal segmental glomerulosclerosis, by focal we mean that we have single glomeruli involved, and when we say segmental, it means only one segment of the glomeruli is involved. The term sclerosis would mean that we have pink hyaline deposition. That is because of the increased permeability to the plasma proteins, which is the case of the nephrotic syndrome. The morphology in the FSGS would be effacement of the fruit processes in the electron microscopy. Now recall that I have said earlier that MCD may progress to FSGS. Okay, so by that you can remember that FSGS and MCD are related, but MCD is in case of the children, while the FSGS is mostly presented in the adults. Okay, so effacement of food process is seen in both of them. Then other features that we have hyalinosis and sclerosis, and that's not also hard to imagine because I've mentioned that sclerosis means hyaline, pink hyaline material, and that is in the focal or segmental parts. Then immunofluorescence is not very important over here. You can skip that if you want. The proteinuria is non-selective. This is in contrast to the MCD, and we have higher incidence of hematuria, although hematuria is a feature of nephritic, but we also see it in nephrotic syndrome. Now, the progression to the end-stage renal disease is there, or you would see the tubular atrophy or the interstitial fibrosis in advanced cases, and MCD may progress to FSGS. The response to the steroids is poor, and this is in again contrast to the MCD. Okay, HIV nephropathy, we only need to know briefly about it that the collapsing variant is most common, and it has relatively poor prognosis, and the incidence is decreasing because of the HART, which is the highly acting antiretroviral therapy. Now, next of our diseases are membranous nephropathy and membranoproliferative glomerulonephritis. But before we go over there, let's have a brief look over the normal structures of the glomeruli. So this would be our endothelium, and this is the visceral endothelium. So it has the endothelial cells, which are fenestrated, of course. Then we have the basement membrane. You can see that we have the lamina rara interna. Then we have the lamina densa and the lamina rara externa. So the depositions are various over here. If we say subendothelial deposits, the deposition will be here. And if we say we have the intra basement membrane or within the basement membrane, the depositions are usually here. Now, if we are saying we have subepithelial deposits, then we would have the depositions over here. So because these are the epithelial cells, recall that these are the visceral epithelial cells and these are the parietal epithelial cells. Okay. So those are very important to understand about the depositions in the various diseases. So that's all over here. Now, the membranous nephropathy is the diffuse thickening of the glomerular capillary wall, and that's because of the subepithelial deposits. Okay, so let's get one step backwards and understand. Let's say we have the basement membrane. This is the basement membrane, and we have the endothelial cells over here. Then we have the visceral epithelial cells. Now, when we say pathy, we have the immunologic basis. Actually, it is an immunocomplex mediated disease, but we can't show the inflammation. Recall that gastropathy, we have the no inflammation, but we have the immunologic basis. So similarly, no inflammation. That's why the immune complex move all the way downwards to subepithelial region. Okay. Now in MPGN, which is membranoproliferative glomerulonephritis, we either have intramembranous, which is the type 2 MPGN, or over here around the subendothelial region, and that's because we have the glomerulonephritis. So itis shows inflammation, and that causes us to think that yes, the deposit should be near to the endothelium because it has inflammation. So that's the way you can remember. Okay, and again, it's easy that the first one is the MPGN1, Then in the basement membrane we have MPGN2, and finally subepithelial deposits we have membranous nephropathy. So it goes in a line, first MPGN1, then 2, and then membranous nephropathy. The cause of membranous nephropathy is usually idiopathic, but it is associated with drugs like penicillamine, NSAIDs, or ACE inhibitors. Then the solid tumors may also be involved, like the lung, colon cancers, and the melanoma. Then the patients of SLE, they actually can present with nephritic or nephrotic, but if they present with the nephrotic syndrome, then it's the because of membranous nephropathy. And now the most common presentation of a lupus patient is nephritic syndrome. Okay, now in the lupus patients you can also see the minimal change disease or the MPGN, and the focal nephritis also, or the sclerosing lupus nephritis. So we tend to call this a full house effect. Okay, the lupus patient can have various syndromes, but most commonly it presents with nephritic syndrome. If it presents with the nephrotic syndrome, then most commonly it is associated with membranous nephropathy. Okay, all other causes of the diseases which are related to nephrotic syndrome, that is the FSGS, MCD, and MPGN, are also seen in the lupus patients. Okay, now the HBV, HCV, HIV, malaria, and syphilis. These are all linked to the membranous nephropathy. And recall that I have mentioned that it is an immune complex mediated disease. So the HBV antigens and the treponema antigens provide the immune complex as the planted antigens, and they form immune complex which are deposited subepithelially. Okay, as I've already mentioned, it is an immune complex mediated disease. Now, recall that I mentioned earlier in the video of the nephritic that PSGN is also immune complex mediated. Then what is the difference? Actually, the PSGN involves the streptococcal antigen and antibodies deposit on those antigens. While in case of the membranous nephropathy, we have the antigens usually of the self, or which are planted antigens. Okay, and they finally they move towards the subepithelial region, and the presentation is actually also different because this is the nephrotic presentation, the nephrotic syndrome, and those are the nephritic syndrome. Okay, so PSGN is in the nephritic syndrome. Now the antibody complex with the self-nuclear antigen in case of the SLE, and HBV or the treponema antigens form the immune complex, as I mentioned. Then the autoantigen, if it's there, it's actually phospholipase AR2 receptor. Now that you can remember, but there is a theory behind this, that there is a megalin protein which is actually seen in the mouse kidney, I think, or horse kidney. So because of that, there is they have seen those cells autoantibody against these receptors, and this is the human counterpart of the megalin. Okay, light microscopy would show the diffuse capillary thickening, and the deposition is granular, and that's because we have an immune complex mediated disease. Recall, I mentioned in the nephritic video that the immune complex mediated disease have a granular immunofluorescence pattern, while the antibody mediated disease, like the Goodpasture syndrome, have the linear immunofluorescence. Then we will have the subepithelial deposits, and I made it very clear that because the inflammation is not associated, because we say nephropathy. Okay, and because of that the immune complex form and they go down. Now the particular feature of the nephropathy, membranous nephropathy, is we have something called spike and dome appearance, and that's because we have the basement membrane, and here we have the subepithelial deposits over here. This is endothelium. Okay, so we have the epithelial deposits over here, and now the basement membrane is being deposited over here in between. So we have this basement membrane being deposited over here, so we have spike and dome appearance in case of the electron microscope. Okay, it's the cause of the nephrotic syndrome obviously, and the proteinuria is non-selective. It has a poor response to steroids. Now, the membranoproliferative glomerulonephritis is the proliferation of the cytoplasm of the mesangial cells. So we also call it as mesangioproliferative glomerulonephritis. Now, based on the location of the deposits, there are two types: subendothelial deposits or the dense deposit disease, in which the deposition is within the basement membrane itself. I have mentioned that let's say this is the basement membrane, and if the deposits are subendothelial, it is MPGN 1, and if they are in the basement membrane, it's MPGN 2, and if they are subepithelial, it's membranous nephropathy. It's an easy way to remember, guys. You can remember all of those easily over here. And I've also mentioned that because we have nephritis, glomerulonephritis in MPGN, the deposits are over here near to the capillary endothelium, so it is subendothelial. Okay. Now, the pathogenesis involves the immune complex or the complement pathways, and the antigens which are planted are derived from HBV or hepatitis C infection. The type 2, that is a dense deposit disease, we also call it as the C3 glomerulopathies. Now, this requires a bit of explanation because what is the C3 nephritic factor? Okay, so for the activation of the complement pathway, we need to convert the C3, and for that we need the C3 convertase to convert it into C3A and C3B. You know that. But for the C3 convertase to be activated, some factors are required. Now, the C3 nephritic factor, what it does is that it stabilizes the C3 convertase and it leads to an overactivation. So more amount of C3A and C3B are formed and increased complement pathway. Now, the C3 plasma levels would decrease. Okay, so this is one of the diagnostic feature, that the C3 levels decrease in the blood. Okay, the deposits in electron microscope are subendothelial, I mentioned. Then the deposits are granular. That's again because the immune complex mediated disease is there. And yes, we have something called tram track appearance. And why do we have a tram track appearance? It's very easy, guys, because in the light microscopy, whenever we see something, we have this deposition over here in the between, and this intramembranous deposits, or if we say we have this endothelium, then all of these deposits look like they have the tram track appearance. So this is the also called the double contour pattern or the splitting of the basement membrane. Okay, so both of these are seen because of the deposits which are intra membranous or the subendothelial. Okay. The MPGN type 2, we have dense deposits, but they are within the basement membrane, and the tram track appearance and the double contour pattern are all the same, and that leads to splitting of the basement membrane. But the difference is that we only see a C3 in the immunofluorescence. Okay, and I mentioned that C3 nephritic factor is that which causes the excess activation of the complement pathway, and concurrently the C3 levels in the blood would fall. Now, the patients of the MPGN may present as nephritic or nephrotic syndrome. Now, in the diabetic nephropathy, they will have the nephrotic syndrome, but all of them stem because of what? Microangiopathy. Okay, and in what happens in microangiopathy is that we have high serum glucose in the diabetes that leads to the non-enzymatic glycosylation of the proteins of the glomerular basement membrane. Then we have the leaky blood vessel walls also because again of the non-enzymatic glycosylation, and this leads to loss of plasma proteins, and they deposit as hyaline deposits, and that may lead to sclerosis also. Now, because we have leaky blood vessels, so it leads to hyperfiltration, and hyperfiltration again leads to microalbuminuria. In diabetic nephropathy, we have three types of lesions: in the glomerular, then the vascular, and the pyelonephritis. Now, in the glomerular lesion, we have the capillary basement membrane thickening, and that you can easily imagine because we have the deposition of the plasma proteins that may lead to sclerosis or hyaline depositions. Now, this hyaline deposition, okay, occurs in case of hypertension also, but over there it's again because of the increased pressure, and in diabetes it's because of the microangiopathy, or I must say the non-enzymatic glycosylation. Okay, one of the characteristic feature is that we see kimmelstiel Wilson nodules. Now, what are these? These are actually intercapillary nodules which are highly pink in nature, hyaline, and they are seen particularly in the diabetes mellitus patients. Okay, so it is one of the characteristic, or we can say the pathognomonic feature of the diabetic mellitus, diabetic nephropathy. Yes, of course, in the vascular lesions, we would see the hyaline arteriosclerosis, and you know that we have pink hyaline deposition because of the microangiopathy, and especially it is different. Why? I'm stressing over here is that usually if a patient presents with efferent arteriosclerosis, then it's almost always associated with diabetes mellitus. Then atherosclerosis, diabetes patients are obviously at increased risk of atherosclerosis, so renal atherosclerosis can also be there. Pyelonephritis, and you guys know that in the diabetic population we have increased risk of infection. So particularly the papillary necrosis is seen in the pyelonephritis, which is having a poor prognosis, and acute or chronic infection both are common in the DM. The ACE inhibitors are particularly useful for slowing down the progression of the diabetic nephropathy. Usually these patients also have hypertension, so sort of we are killing two birds with a one arrow. Now finally we will see the amyloidosis. Kidney is the most common organ involved in the systemic amyloidosis, and actually it is the most serious organ which is involved also. Now the amyloid deposits are particularly in the mesangium. And now if you see that we have this capillary lumen and the deposits are being there in the mesangium, what they do is that they compress the capillary lumen that lead to renal ischemia. Now the characteristic feature of any amyloidosis, is the apple green birefringence in the plain polarized light. And can you say how do we stain them? Yes, we stain them with the congruent stain. With this, we are done with the nephrotic syndrome, and hope you liked it, guys. Subs if you loved it, comment the queries down below, and do subscribe the channel. See you in the next one.